Welcome to Oncology Revolution, where science meets care to transform the cancer journey. We explore evidence-based strategies to enhance quality of life, promote longevity, and empower patients and professionals to thrive beyond cancer.
Hi everyone, and welcome to another episode of the Oncology Revolution. My name is Raquel Maris. I'm an occupational therapist and project coordinator at the European School of Lifestyle Oncology. I'm the host today, and I'm excited to share that we are exploring an area that is essential to integrative cancer care, which is the role of clinical nutrition in oncology. And to guide us through this conversation, we're joined by someone who brings an incredible depth of expertise and vision to this field. Shelby Yaceczko. Welcome, Shelby. Thank you so much for being here.
Yeah, thank you for having me.
Could you start by telling us a bit about your background and what led you into the world of clinical nutrition, especially in oncology and critical care?
Yeah, definitely. Hi everyone. My name is Shelby Yaceczko. Just for kind of background context, I'm a registered dietitian with an advanced certification in clinical nutrition, and I also hold a Doctor of Clinical Nutrition degree. Um, my background's really interesting. I actually, when I started out in college, I was actually going through to be a professional dancer. So I ended up moving into kind of a sports nutrition world at first, working at the collegiate level and the Olympic and national level. And I loved the combination between exercise and muscle health and nutrition. And I actually think that's what that like synergy actually led me into wanting to work into critical care for the next 7 or 8 years of my professional career path. So I worked in really, intensive care units, a lot of surgery patients, a lot of cancer-based patients or cancer populations in the critical care unit. And then a couple of years ago, I moved into the ambulatory setting because I realized that I was able to bring my passion of the sport nutrition world and the importance of nutrition being fuel, and how that can help support patients who need rehabilitation care. An oncology population is a huge one in that arena that really, really could use that extra support from a nutrition side and from an exercise and muscle health side. So I was able to bring like that synergy into my practice and in what I do, and founded a digital health company around that kind of mantra. So it's been a fun journey, and definitely not one many people I think go to, from working with like professional athletes to cancer care patients in the outpatient setting with critical care mixed in the middle. So that's been my journey though.
Thank you so much for sharing. It's a very interesting story for sure. Now, turning to where we are today, in your view, what are some of the biggest challenges when it comes to delivering effective nutrition care to people with cancer?
Yeah, and I think if you actually talk to providers or people who work in cancer care or oncology providers, everyone wants to have these type of programs that have nutrition, that have mental health services, that offer like cancer rehabilitation and exercise programs. But the reality is it's quite scarce still. And I think that's probably one of the most significant challenges, is just lack of streamlined resources, lack of evidence-based practices that get synergized into clinics and programs and things. The guidelines repeatedly say that we need strong nutrition programs, we need strong exercise programs, we need strong mental health programs. But we don't really see that really happening when you go out for cancer care in many places. We know that most patients, roughly 80% in the United States, are getting their cancer care at the community level, typically outside of a academic center that has more robust resources. So lack of resources is definitely one. Another is just cancer disparities. We know by definition, if you have a lower income, if you're living in certain geographical regions, education level, these different things can largely create cancer disparities around your prognosis, and some of your clinical outcomes and just your care experience. So that's something I'm always trying to be really, really mindful of when I'm working with people to help provide that extra level of navigation. I'm just not sure that everyone has that time or resource to be able to do that. The other big thing is definitely just misinformation. I saw a report recently that roughly 80% of health information that's posted online has some form of misinformation, whether it be a fact or statistic that's incorrect, or something that's just not true, not good evidence. So I think the health misinformation that's available on the internet can be a huge problem. We see patients who change their minds of things like their cancer treatment or what their care plan is going to be because of something they read on a Facebook group or a blog online, which is really, really scary. And that can unfortunately lead to devastating effects. I've worked with many patients who they've changed their whole kind of cancer care course because of something online. And unfortunately, by the time they come back into office, they may not have the same option that was available before, leading to a negative effect for them. So I think, realistically, I'd say my top 3 challenges I probably see right now are just the resources and lack of solid systems in place for cancer-related support services. Cancer disparities, I think we have a lot of work to do. And I think health information.
For sure. I completely agree with you. And that's why it's so important to have podcasts like this one, that we can share the information, the most important information in the area. Thinking about the healthcare teams we work with, how do you see the role of the nutrition professional evolving within the multidisciplinary care?
Yeah, that's a good question. I think it's definitely evolving. I think we have a ton more work to do. I think we're trying to move from a reactive to a proactive care state. So I think we're starting to see even more like cancer prevention programs start coming up, or just having cancer screening, genetic screening for individuals who may qualify, which can then lead to a dietitian professional being able to go in and counsel patients as far as, hey, these are foods that make more sense for you. These are more anti-cancer based foods, more foods that can help reduce things like inflammation in the body and support your metabolic health. So we're moving a little bit more into the reactive space or the proactive space versus the reactive space. It's a slow shift. I gotta be honest with you. I think, some providers are still very much in that reactive space, and some healthcare systems of just kind of treating the problem or being there for the chronic disease. But I am seeing more and more prevention based. I would also say the integration of dietitians into the professional teams. So we're starting to see cancer centers more and more hiring dietitians into the cancer centers to support or offering those types of referrals on the care team, as well as on the inpatient side and the hospital side. I think a lot of centers are really trying to improve their staffing ratios. So there's more dietitian availability because there's more and more consults, right? When providers realize the importance of having registered dietitian for certain patients, particularly your oncology patient population, they will put in more referrals. And more referrals means you see a higher volume or higher patient volume each day. So I know just kind of in my industry in the nutrition world, we're hearing a lot of institutions trying to put in more staff ratios so that way they can keep up with the consults and keep up with the demand, both the hospital side and then the ambulatory or the outpatient side.
Those are great news, and I wish it continues to grow and goes to the great direction that we need cancer care to be. Let's talk about malnutrition, which is still such a critical yet sometimes overlooked issue. What do you think are some of the most effective ways we can improve?
Yeah, I think number one, just being aware of what malnutrition is, for one, right? So malnutrition really being this undernutrition state where an individual has not been eating consistently, or they've been on things like liquid diets or without food because they've been in the hospital for prolonged times. They're actively losing weight, they're actively losing muscle. This is really that kind of like malnutrition trifecta. We're seeing the inability to get in enough nutrients combined with unintentional weight loss. with the added muscle loss on top of it. And that really is just creating a state for disaster for somebody. Your body can only handle so much unintentional weight loss and muscle loss before, it breaks down. And I tell patients that every time I see them about the importance of malnutrition. We're just like a car. If we don't have the proper fuel, your car is going to break down. That's inevitable. It's just about when and how bad the breakdown is. So malnutrition is something, number one, you've got to be aware of what malnutrition is to be able to actually identify it, screen for it, triage it. How do we want to capture these people? And then treat it. How do we want to intervene with the malnutrition? So I think from an improvement lens, it's the awareness around like the complications and risk factors associated with malnutrition is critically important. We know somebody that's malnutrition has longer hospital length of stays. They have a lot more treatment-related complications like treatment toxicities. They become quite frail. They can lead to poor functional status, poor sleep. All of these things really become like a domino cascade. So earlier and regular screening with the appropriate screening tools that are meant for oncology populations, one of which is like the malnutrition screening tool, which is really, really popular in the States, otherwise known as the MST, which is a validated tool in both the outpatient and inpatient setting for oncology population. And then figuring out, once we've identified somebody who is a high risk for malnutrition or we're concerned that has malnutrition, we send them to the proper care. And really those professionals are the registered dietitians, particularly those with extra training in oncology. Registered dietitians can mean many things. You can be a registered dietitian for lifestyle medicine or for public health, or acute care, clinical medicine, or oncology, right? So there's so many specialties similar to physicians. So it's important that you're working with a registered dietitian that has knowledge and expertise and extra training in oncology care, if that's who you're seeking, so they can really give you the extra care that you need and you deserve. So that way you know really the best tips and best evidence to support your body. So once you've been able to triage and work with somebody like a registered dietitian, having a follow-up plan and having that integrated into your care plan. It becomes really difficult if you have a provider like a medical oncologist or radiation oncologist or a surgeon, if they just say it doesn't matter, it's this, everyone loses weight or everyone is not going to eat very well. That's not helpful. And so it's also making sure that the providers are on board with the importance of nutrition, so that way the patients can integrate that into their care plan and use it every day and know that it's going to be meaningful for their clinical outcomes.
For sure. And you were mentioning the tool of the assessment, and I would like to ask you, are there any other particular tools or approaches that you found are especially useful to use in cancer care?
Yeah, so there's different validated tools that are specific to nutrition screening, and then there's different validated tools that are specific to like nutrition assessment and identifying malnutrition. The two I'd say that's most commonly used for identifying and recognizing malnutrition in the States is the ASPEN and criteria for malnutrition that came out in 2012 by White et al. Is the author of that group. And the other one is the GLIM, which is the global leader, the larger level scale malnutrition recognition and diagnostic group at the more global level. That one's a bit newer and uses phenotypic and etiologic criterias. So you can go and look up those kind of papers and the work that's been done in both of those author groups. I'd say it just really depends on where you work. So I've worked in places where we use GLIM and others we're using the ASPEN and AND, but I think both can be effective tools in recognizing malnutrition.
Great. Thank you for sharing. Focusing now on body composition, and which is getting a lot of attention, but perhaps still not enough. How important do you think body composition assessment is in oncology? Are we doing enough to address this muscle wasting, sarcopenia? What can we do more?
I think we're absolutely not doing enough. I don't think it's routine at this point or standardized for patients when they're going through oncology care to get body composition assessment done. I'm a huge advocate of it. I think it brings a lot of light and can shed awareness onto patients as far as how they're doing. If you have somebody who's progressively losing muscle mass, or they're considered sarcopenic on things like their CT scans, which they may be getting done, which is a quick, simple read by a radiologist or with some of the new imaging software that's out. When we know that, we know we need an extra layer of intervention, or we need extra support to that individual to support their muscle health. And there's different ways that that can be done. And I think there's new research always coming out around like muscle health. This goes back to my athletic brain saying, okay, it's not just nutrition, it's also the physical activity component, good sleep, good hydration, all of these other wellness pillars. So we know that low muscle mass or the progressive loss of muscle mass can be associated with a lot of negative things that somebody doesn't want, like increased toxicity of their treatment regimen, the inability to go through their treatment regimen as prescribed, or there's more interruptions for them or stops. They may have poor surgical recoveries if they go through surgery. They have general kind of weakness in this picture around frailty. They can have reduced just physical function, the inability to get up the stairs, the inability to make their food or to shower without having help. And oftentimes, unfortunately, we see shorter survival and reoccurrence in some of these patients who are having these kind of undernourished, frail, low muscle mass pictures. So these are incredibly important. And I think I just saw a really great meta-analysis published that's really showing like muscle mass is incredibly important in the cancer care journey. I just don't think right now there's many people who recognize that. If they do, they don't always have an intervention or a next step in place in their practice to actually look at muscle mass and use that to help support their patients, which I think should be really standard of care.
Completely agree. And when it comes to protein, especially in patients who are catabolic or critically ill, how do you approach meeting their needs in a clinical setting?
Yeah, so when you're looking at particularly a cancer patient who's in the intensive care unit, they're in this really robust inflammatory state. That's what critical care is, right? Especially if you throw in things like sepsis or you throw in things like a big surgery, you're just adding fire to that patient's inflammation status. We see that when we draw different types of blood work that can show the inflammatory levels of the body in critical care. So when you're thinking about nutrition assessment, generally speaking, your protein needs are going to be higher because you're in such a catabolic or a breakdown type of state with metabolism. So we tend to see the protein needs can be almost twofold for some people in critical care. And that depends on other things, like if they're on renal replacement therapy or if they have wounds or surgical wounds that need to be healed up. So thinking about all the different factors that can impact nutrition requirements and metabolism is how you can then individualize protein needs. There are general guidelines. ESPEN's put out, of course, great work as far as just nutrition requirements or estimated nutritional needs in patients in cancer. I think ESPEN's one of the few organizations that has really done that. We also have to think about the goals around muscle preservation in treatment, right? If you have a cancer patient that just went through a big surgery, like a Whipple surgery or a total gastrectomy, or has a new ostomy, these things can very much change how much protein the person's going to need. And we have to figure out how we're giving that protein. Is it through diet? Is it through enteral nutrition or tube feeding? Is it through parenteral nutrition? Because the modality of how we give protein also changes how much the energy needs may be, versus if it goes directly into the bloodstream or if it's going through the gastrointestinal tract. With some cancer patients, they just have a degree of malabsorption, meaning that despite how much we're giving, they're not absorbing everything that we give them. So sometimes we have to overshoot with the understanding that they're going to lose some of that along the way.
Thank you so much for clarifying. And a point that we have been speaking since the beginning is that we need to be doing more. And you have been involved in mentoring and clinical education, which is so valuable. And here at the school, we actually value that so much. So I would like to ask you, from your perspective, what knowledge gaps do you most often see among healthcare professionals when it comes to oncology nutrition?
Yeah, this is actually one of my research interests, and I just did a small study kind of looking at just like perceptions of oncology healthcare providers. And I think it goes back to what's, previously published and what I kind of see just in my practice too. I think people have a hunch. They know nutrition, mental health, physical activity, all the wellness things are important. They do believe that in oncology care. I think not everyone knows how to approach it. And it's not their fault. It's not something that everyone learns in their training. But it's this kind of concept of, I'm not totally sure how to bring this up with a patient, so I'm not going to ask about it. Or if I bring it up, I don't know what to do with the information. So I don't know how to refer to a dietitian. I don't know how to refer to a physical therapist or a clinical exercise physiologist or a psychologist. And there can be stigma with these things, right? If you're picking up risk factors for depression and anxiety, some providers they don't know what to do, or they don't know where to refer. So I think everyone, in my opinion, we need to do better at creating systems in place. So each provider really being responsible for identifying, what is my system for screening for these important things? What's my system for then taking care if screens are positive, or I'm catching on to things or catching on to risk factors? Where do I get to send them? Because let's be honest, a conversation with a clinic, with a physician saying you need to eat more, you're losing a lot of weight, I need you to eat more small, frequent meals, it's just not helpful. I've had patient after patient tell me that, they've been asking for referrals and they don't get them until later in the game, until it's really, almost really too late at that point to really intervene when you've got like a cancer cachexia picture. We kind of miss some of the window and opportunity. So I think a knowledge gap is being proactive in screening and referring, and understanding that each person on the care team plays an important role. And you don't always have to be that one person to kind of field everything, because that's why you have the interdisciplinary care team model and that like integrative team. And if you're working in private practice or you're working in kind of a private clinic setting, be sure to set up those resources or have those referrals available for your patients so they can still get the best standard of care and have the best care experience to work with professionals that can help them.
Sure. Let's look into the future. Where do you see the field of clinical oncology nutrition heading over the next 5 to 10 years?
Yeah, I think technology is going to play a huge role in cancer care, whether that's for cancer detection, cancer screening, nutritional management. I think we're starting to see a little bit coming out on like personalized medicine, and in the nutrition space, understanding what type of diet pattern is most appropriate for what type of tumor type, or what type of genetic sequencing, or what type of treatment that somebody's on. Like, how can we use nutrients to support their actual treatment, chemotherapy, chemoradiation, what have you, their surgery regimen. So we know the basics. We know a bit about macronutrients, and we know general energy needs and these, big bucket concepts, but I don't think we know enough about like specific types of phytonutrients and antioxidants. I think that's an area we're learning more about, which is really exciting, and understanding if there's particular nutrition interventions based on like metabolic phenotype, or their own genetic profile, if they're doing genetic sequencing or testing. I think we're also going to see more research in the microbiome data, which is basically all the bacteria and the bugs in the gut. So I think once we start learning more about how to personalize nutrition recommendations based on the microflora, that will be fascinating. We're still very early in that research. But we are seeing like centers dedicated to microbiome research, and many of those centers are looking at cancer care models, whether it be for prevention or whether it be for during an active cancer journey.
Sure. Thank you for sharing. Before we wrap up, what's one message you would like to leave for our audience?
Yeah, that's a good question. I would just say don't underestimate how important nutrition and wellness is in patients going through cancer care, or if you're going through a cancer care journey yourself. Remind yourself very, very much that you need fuel to fight cancer, and you need fuel to be able to recover. And fuel comes from your food, your beverages, things like your sleep, things like your stress levels and stress management, as well as your exercise and your activity. So it's really this like cobweb of wellness tools in your toolkit, is what I like to say. What tools do we need to add to our toolkit, and what tools do we need to take out and modify? So that's kind of a nice way to think about it. And if you're a provider working in cancer care, just really recognizing how much value all of these incredible supportive care disciplines, like our palliative supportive care teams, our physical therapists, and our exercise cancer professionals, our mental health providers that are specialized in cancer care, because realistically having that integrative team is so powerful. And I will, time and time again, patients come to see me and they tell me things that they haven't told their surgeon or their oncologist. And so sometimes you end up getting information that can be incredibly helpful to their care journey, and you're able to then work with the provider or the champion physician to improve care outcomes for that person. So it can be a really rewarding experience in field if that's something you're looking to go into too, if you're an audience member thinking about this area of work.
Thank you so much, Shelby. It was truly a pleasure to have you. It was a great conversation. Thank you for sharing your insights and your expertise with us today.
Yeah, thank you for having me.